Now, just to share a little bit about our mission at Migraine and Headache Australia, it's really threefold. One is to provide trustworthy and reliable information. Another is to fund research, and we aim to fund at least one migraine or headache research project each year. And then we also aim to advocate and support people living with headache and migraine conditions and diseases. And so as part of that, we've been quite active. And I'll cover off one of these things, one of these elements each day of the week as part of our webinars. And so today, I just wanted to share, given that the context of this presentation is actually going to be around treatments, it's probably appropriate that we talk about PBS listing. And so I know a number of you have been following this very closely, but for some, this might be new to you to see. So we've had recent news about Vyepti, which has just recently been recommended by the PBAC, which is the Pharmaceutical Benefits Advisory Committee or Council. And they advise basically like what should be listed and what shouldn't be listed on the PBS. And there can be quite a bit of a time lag between what gets recommended versus what gets listed. So whilst Vyepti is recently recommended, it is not yet listed, and they're currently in negotiations. But you can see Ajovy, Emgality, Botox have all been approved and listed on the PBS. Aimovig, which was one of the first anti-CGRPs to apply for PBAC listing or PBS listing, still has not been accepted on the PBS and has actually withdrawn its application. But it is available. It is TGA approved, just not under the listing. And so just to make sure that you're all in the right place, if you have migraine or headache, you might be a parent, a partner, or a caregiver, you are just as welcome as everyone else. Thank you for being here. It shows that you really do care, even though you may not have it yourself. If you'd like to connect with others, we have a support group as well on Facebook. It's not everyone's favorite social media account, but it is there for people that would like to utilize it. And there's obviously no charge. That's free to use. You can look that up or message us, and we'll happily provide the link for that. And then of course, if you'd like to ask a question, we're going to have our expert coming on very shortly. Before we do, just a quick sort of quick tip on how to ask questions. So you can actually switch modes and go into Q&A mode, or you can just send a message or a text. That might be one of the best ways to ask your question. It's up to you. We've got a moderator here, Anik from Migraine and Headache Australia, will be helping out as well, and in the chat, making sure that everyone is getting as many questions answered as possible. So with that, I'd like to introduce our speaker, our expert, our headache specialist for tonight, which is Dr. Michael Eller. He specializes in migraine and headache disorders. He also knows a whole lot about trigeminal autonomic cephalalgias, or TACs, which is of which cluster headache is perhaps the most famous of. But he also looks after a lot of other general neurological disorders. He's a neurologist after all, and so he has expertise in these other areas, which you can read on the slide. He's studied in the US underneath some world-leading migraine and headache experts, such as Professor Peter Goseby, who we've had before. And he's currently based in Melbourne at working at Monash Neurology and the Royal Darwin Hospital. So we'll transition now over to Dr. Eller with his presentation on new treatments and treatments that are coming soon.
Thanks very much for joining me in this session. I'm very excited to get the invitation to talk about this really important topic around newly available and coming soon treatments. Most of you would be who are tuning in would be aware that there's really been this there's revolution in terms of migraine treatments that have become available around the world. Two of which are available on the Pharmaceutical Benefits Scheme in Australia. These are calcitonin gene-related peptide pathway medications. And they really are the first rationally designed migraine preventives that humans have developed. All the medications and other interventions in the past have been repurposed effectively for this condition. Really chronic disorder, as you know, for many people. Very common disorder too, affecting around 15% of people. It's very extremely disabling. You've probably heard from other talks and probably aware of, given you're tuning in and have an interest. So there's lots of incentive to go after this condition, which is really as common as asthma, but has had a lot less funding. 4 medications that work in this pathway, monoclonal antibodies that is, have been developed, and they all demonstrate efficacy. So that is to say, they can all be extremely effective in individuals, both in people who have now and then headaches and migraine, and people that are plagued with headaches most days, with significant worsening several days a month. They 3 of the 4 compounds, monoclonal antibodies, work on the small protein itself, calcitonin gene-related peptide, CGRP, and one of them, the first that was available in Australia, works on the canonical receptor. What I mean by canonical means it's literally the CGRP receptor. There are, in fact, a number of receptors that calcitonin gene-related peptide hits. So there's some complexity in the system, like most systems. They all 4 medications show a roughly similar magnitude of effect, though you can tease it out in different ways, and they all have an excellent safety and tolerability profile. So that's one of the themes. They're well tolerated, and they can be extremely effective. Ultimately, it comes down to whether you're someone where there are no particular issues with using the medication. So, for example, you're not pregnant, they shouldn't be used in pregnancy or in anyone who's trying to conceive. And you don't have any other relevant potential reasons not to be able to access the drug. If you're in that group, then it's just a question of, does it work for you or not? And you'll see for many human beings, it does work. So what is calcitonin gene-related peptide, CGRP? Well, it's widely expressed around the body. I'll come to a slide later in the talk where I pick apart some of the different organ and body systems where it is expressed. If you think of a cerebrovascular smooth muscle cell, so these are vessels blood vessels in the brain, for example, and within them they express receptors for calcitonin gene receptor, or for CGRP. I'll just start saying that for now. It's a bit easy to say. On the top right of your screen, you can see CGRP itself. It's a small protein, a peptide. And below that, you can see the CGRP receptor itself. Where do the different compounds I'm going to talk about today principally hit? Well, the anti-CGRP receptor antibody, and there's only one example of that I'll talk about today, which is Erenumab, otherwise known as Aimovig, that directly attaches to the receptor itself. I'll talk about the class of drugs called the Gepants, which are very small molecules that block the receptor itself. Talk briefly at the end of that. They're coming. They're available already in a number of countries around the world, in particular America. And then there are anti-CGRP antibodies, which hit on the protein or attach themselves to the protein themselves. So that's anti-CGRP antibody. So examples of that are Eptinezumab, also known as Vyepti, that's the trade name, Galcanezumab, also known as Emgality, and Fremanezumab, also known as Ajovy. Triptans themselves, which you may be familiar with, they're widely used for the acute treatment of migraine, have been available since the mid-1990s. They hit serotonin receptors, so 5-HT1B and 1D receptors, which are on the trigeminal nerve itself. The trigeminal nerve subserves a lot of the discomfort, or it mediates much of the pain sensation in the head. The other system that is involved with pain sensation in the head is a branch of the second cervical nerve root, which innervates the part of the head called the posterior fossa. So what I'm going to do is talk about each of the 4 different monoclonal antibodies and show you some data around their effectiveness, tolerability, and a few different aspects of all of the above, so you get a better feel for just what they do, what the magnitude of effective is, and just some other elements which will be informative for you. So Erenumab, Aimovig, the first drug of the CGRP pathway medications that was studied and then subsequently was licensed around the world and now used in thousands, probably millions by now, of patients worldwide. On the right-hand side of the screen, I'm looking at 4 different colored graphs. The green bars represent the 140 milligram dose. It's a every 28-day medication, while the brown bars are relevant to a 70 milligram dose. Can be used in either dose, of course. That's where it was studied. And the different shades represent either a 30%, 50%, or 75% reduction in the number of monthly migraine days. And you'll see that around a quarter of patients in the, we'll just concentrate on the green bars, around a quarter of the patients, almost up to a third at the 1 year mark, demonstrate a more than 75% reduction in migraine days. So really remarkable switching off of migrainousness. Over half the patients that received the drug had a more than 50% reduction in migraine days. So really significant reduction up to well, 80% once you get up to 6 months and 1 year of people on the 140 milligram dose had a more than 30% reduction, which for many people will be meaningful. Real world data, if anything, are as good as that, or if not better. So data from a number of groups around Australia that were pulled together and published in 2020 show, this is around 170 patients at baseline and also at 3 months, went from 25 headache days a month to 16 and a half. And then that was sustained at 6 months' time, where it was down to 15.6 to 130 people. So not, it's about 40 people didn't continue past that 3 month point. Whereas the monthly migraine days, so the more severe headaches with more light and sound sensitivity, for example, or nausea, quite an individual thing, go from 20 migraine days per month to 10.6 down to 10. So you can see that it's not just in studies. So this is an initial blinded study and then open label phase of the study. And then the Australian data, both the doctors and the patients knew what they were getting, demonstrate really significant improvement in symptoms. This is another study around Erenumab. Again, an open label. What that means is everyone knows past that initial 12-week study phase where the patients and the clinicians were blinded. People know, from that point what the medicine they're on is, and need to be willing to continue it. So, this is a theme around many studies of medications, almost as a gesture of goodwill, but also in terms of data collection and generating buzz around different drugs. It's not unusual for medications to be, discrete periods of time when drugs are trialed to be followed by a period where they can be accessed, if they're of benefit and if the patient wants to. So we've got 5-year data for Erenumab, showing both, this is the 170 milligram dose and 140 milligram dose, showing this reduction of migraine days of around 6 per month. It really may sound like a lot to you or not too much, but when you look at more finely granulated data, the headache days are down by 5, but the monthly migraine days are down by even more. And then perhaps this is a theme of this talk, the most important or useful metric are this concept of the 50% response, 75% response, and 100% response. It captures the magnitude of the effect it can have for individuals much, much better than on average amongst a couple of hundred people, you've got 2 less headache days per month, for example, or 4 headache days per month. So here with Erenumab going out to 5 years, almost 3/4 of patients had a 50% response, almost half of them had a 75% response, and roughly a third had a 100% response. Pretty remarkable. So I'd love to see more data like that reproduced. Keep in mind, the people that stay on the medicine, the people that are responders initially. So, if you've been on it for 3 months and it didn't do anything for you, you're probably not going to continue it for 5 years. And it also excludes, to a degree, the people that had side effects or problems from it who also wouldn't continue it. So it's a select group, but what it tells you is that the people that basically the people who respond can often continue to respond going out to 5 years. You may have heard that there are these things called neutralizing antibodies. So the body can generate an immune response to this foreign protein and target it with antibodies of its own. But they seem to not be too much of a problem for most people, in the sense that they might be there, but they're not necessarily curtailing the effect of the drug. So the second drug I'll talk about today is Fremanezumab, also known as Ajovy. The graphs look a little bit different to the previous images that I've shown, and all of these graphs are from the principal studies, in part, that showed the effectiveness of these drugs in either chronic migraine or episodic migraine. So people with headache most days, or people with occasional migraine, or even 1 or 2 a week, but headache free the rest of the time. Ajovy shows around less of 4 migraine day reduction per month, which is meaningful from a statistical perspective, and the 50% responder rate is around 50%, like with the other medications. It's very well tolerated medicine again, and unlike Aimovig, it's available on the pharmaceutical benefits scheme. Both the Ajovy and Emgality, to qualify, you need to have failed 3 migraine preventives already, or have some relevant contraindications that mean that you can't try them. And you need to have chronic migraine, so that is headache more than half the month, with a problem that fulfills criteria for migraine more than 8 days a month for more than 3 months. And a neurologist needs to be involved at that prescription stage, where you're considered whether you're eligible for the treatment or not. So that's the barrier for it, but it's available on a script. The graph on the left side of the screen shows a different take on things. So it relates to the MIDAS and HIT6, so 2 different headache disability scores, and it shows how many of the how many categories there's an improvement. And with Ajovy, it can be used monthly or 3 monthly, but it's only licensed as under the PBS, it's a monthly medication. It shows that, you know, of the 50% of people that do respond to the medicine, most of them will have a very significant reduction in disability. So it's not just migraine days or headache days that reduce significantly, but disability around that is also reduced. And it's a theme actually that we don't capture very well in headache neurology or just medicine in general. It's the quality of life scales, patient-reported outcomes. We're coming down to seeing that more and more, that they're really important indices. And, you know, some of the quite rigid and pedantic indices that allow us to prescribe or keep prescribing these medications. And you need to show a 50% reduction in your migraine days to continue to access them under the pharmaceutical benefit scheme beyond that first 3 months. You know, that may not be the best assessment, really. You know, someone might come in and say, oh, gee, I feel so much better on Ajovy, for example, so much better, but the migraine days haven't changed, but their quality of life has increased spectacularly, or the response to medication is so much better, or the intensity of the migraine has dropped. So, you know, that global impression is really valuable, and neurologists and other doctors should be asking about it. I think we'll see more in that space going forward. Quality of life indices is so important. Emgality, also known as Galcanezumab, it's the other drug that's available on the pharmaceutical scheme for people with chronic migraine. It is also available, just like Ajovy and Aimovig, and Eptinezumab, which is also known as Vyepti, for people with episodic migraine who don't qualify under the PBS, but may want to access the drug. And they all have their own programs where with some degree of co-payment, you're able to access it. So under drug company-sponsored trials, for example, drug company-sponsored programs, both Emgality and Ajovy are available if you have episodic migraine at a subsidized cost of somewhere between $260 and $300, plus minus the pharmacy copay. So that's just a rough guide per month of what those drugs cost if you want to access it outside of the pharmaceutical benefit scheme, assuming that you have a neurologist that can point you in the right direction. They need to be involved in the care. In terms of reduction in monthly headache days, you'll see the same theme, you know, around the around 3 to 4 decreased migraine and days per month. But those more important indices of 50% reduction, you know, up to almost 40% in migraine headache days, more than 75% reduction in migraine headache days, around 15% of people achieve that, and around 5% of people, 100% reduction in migraine days with improvements in quality of life. So, you know, that theme, if you're going to be someone that responds to these medications, you'll either be a really decent responder, where it's a really, you know, useful bump to your quality of life and reduction in headache days, or it's a, you know, just absolutely fantastic improvement and just absolutely life-changing. Eptinezumab, Vyepti, the most recent addition to the market, can be used at 100 milligrams and 300 milligram doses. It's approved for use in Australia, but it's not on the pharmaceutical benefit scheme. It's a little bit different from the other 3 drugs I mentioned, which are all injections under the skin. This is an infusion through the vein. So that adds extra complexity, particularly just in terms of being able to access a center where you can have the infusion. the additional costs and the pragmatics of that. And if you have difficult venous access, for example, how do we get the drug into you? Pragmatics. It's a 3-monthly infusion, and it is available in Australia through your neurologist under different programs. We hope that hopefully this year, perhaps next year, that it'll be accepted on the pharmaceutical benefit scheme under perhaps similar rules to what's come so far. But just watch the space; it remains to be seen. The data around Eptinezumab has been validated both with presented the chronic migraine data here. Similar structure trials. Most of these trials, 1 month where patients followed, not on any medicine, and they keep a headache diary, and then 3 months where they've received treatment, and we watch what the diary does, and then, like some of the other studies I showed you, an open label phase out to 1 year where everyone knows that they're getting the real deal rather than placebo. We always use placebo in the initial context. I think it's actually placebo controlled right up to 24 weeks, this particular trial, but we always use it initially because a significant proportion of people, if they think they're getting a drug, will improve. That's not a weird psychological thing. It's just, it's reproduced with surgeries, oral medicines, and intravenous medicines. The magnitude of the benefit regarding Vyepti, if anything, is just a little better than the subcutaneous injections, but it depends how you carve up the data. And the takeaway for you really is that you should come away thinking that they're all roughly comparable, with either and the 100 milligram and 300 milligram dose. While the data is a little different for both of them, both doses are excellent. So these are this relates to what percentage of people have either 50% or 75% response. They're pretty remarkable. For example, here, looking at the 300 milligram dose, patients out at 13 to 24 weeks, almost a third of them have a more than 75% response, with only 7% of people receiving placebo perceiving that degree of response. So really life-changing for almost a third of patients receiving that drug at that point in time. And there are points of caution. I've already talked about how potential for pregnancy means that you should not be on these medications. It could, in particular, affect autoregulation in the placenta, for example. So we'd be concerned around that. It's so widely expressed in the body, calcitonin gene-related peptide. When we first started blocking this molecule in both animals and subsequently humans, collectively, it was almost astonishing how few side effects there were. So it's something that we still need to be very vigilant around, and it's a theme. It's a theme of any drug that comes onto market. It's occasionally 10, 15, 20 years down the track, a signal emerges that we hadn't seen in the initial few years. We've got good 5-year data for Aimovig now, which is largely reassuring. And as time goes on, we'll have more and more data on stretching out regarding the other monoclonal antibodies. Certainly beyond that as well, places like America, where they've had access to these drugs earlier than us, that's a big population of many so-called patient years, patients that have been exposed to the medicines for significant time without really any significant worrying signals emerging, aside from what I've already mentioned. You can see the different body systems, particularly richly expressed around the gut, the immune system, cardiovascular system, the areas that we've been particularly worried about. And I'm going to talk to your neurologist if you have some sort of medical problem, and make sure that they're comfortable prescribing the medicine, because there are some systems where there are theoretical concerns And I have several patients, for example, where at least there's a conversation around any risk of using the drug in that context. So talk to your neurologist if you have any medical problems, and emphasize any concerns that you might have. I'm going to spend the rest of the talk talking about two different classes of medicines, the so-called Gepants. These are small molecules that block the CGRP receptor and get into the brain, as opposed to the monoclonal antibodies that work outside of the brain but influence what's happening within it. My understanding is that we're likely to have at least two medications, probably three, from the class of Gepants available in Australia at some stage. And they're different to what I've talked about so far, because it can be used in both the acute phase, so a medicine that you can take when you get a bad migraine, just like a triptan. So, for example, with a magnitude of response that is roughly comparable to a triptan, so perhaps a little bit lower than for some of the data for powerful triptans like injectable sumatriptan. Around 50% of people respond to that. Around 20% of people respond at 2 hours with headache freedom to the Gepants, whichever one that you use. But that's still really useful. And for some people that can't use a triptan, or have used other medications with only partial benefit or poorly tolerated them, it's another drug that can be used acutely, even if you have something like some contraindications of triptan can be helpful. And unlike things like triptans, regular use never causes increased headache paradox. A paradox which can occur in triptans, though not in everyone. So I'm just cycling through different medicines. Rimegepant has been studied as a migraine preventive. So, affecting the CGRP pathway using this small molecule, both can treat the acute headache, and you can take it every day, and you get data that's roughly similar to the monoclonal antibodies. So in some, with a side effect profile that has some similarities in that you can, for example, develop some irritation of the back of the throat or the mucosa in the nose, occasional constipation, that sort of thing. Togepant, another Gepant. So and this is used. This is data on migraine prevention. So it's sort of roughly comparable to the monoclonal antibodies. So you can start to see we're starting to we now have more tools. And interestingly enough, the Gepants have been widely used in the States for people that are already on the monoclonal antibodies directed against CGRP or its receptor, without any significant safety concerns. So that's reassuring. This is just what I was talking about, putting the Gepants in context. On the right-hand side of the screen, it might be a little bit small, but you can see this, this freedom from pain at 2 hours, which is a common index in research on acute medications for migraine. You can see this response rate of 20 to 30% for a number of different compounds, like a big dose of aspirin or sumatriptan, for example. But you'll be familiar with this if you have migraine or know someone with migraine. Many of the combining a non-steroidal anti-inflammatory drug, for example, with a triptan can be additionally helpful. Or some people can just respond magnificently to a specific triptan, but not a non-steroidal anti-inflammatory. So it's quite idiosyncratic. You really need to experiment with different potential options to see what works for you. The Gepants, Rimegepant, Protropant, these drugs can be helpful with headache freedom around 20%. So that's the general magnitude of effect. proportionally, but if you're an individual that responds magnificently to a Gepant, well, how useful is that? It can be life-changing again. Lasmiditan is the last compound that I'm going to talk about, with 2-hour headache freedom rates of up to 40% on the higher dose. And this is a graph for its use in menstrual migraine, but it's really just a marker to say it can be used in different phases of migraine. That can be extremely effective. So it's a bit different to the triptans. So you'll recall at the beginning of the talk, I talked about 5-HT1B and 1D receptors and how the triptans work on that. Well, the ditans work on the 5-HT1F receptor. So it's a very specific serotonin receptor. And it can be used safely in people with a history of cardiovascular trouble, which is part of its use. And again, there'll be a proportion of people that respond well to this, but not to the triptans, for example, or not to the Gepants. There's a proportion of people that can get a bit drowsy with it. So in the States, the way it's been marketed, you need to not drive for a set period of time, for example, but it's a bit idiosyncratic. So we need to wait and see when that will come to Australia, and just how it will be licensed and with what particular warnings it has. But it's a validated drug, which is useful, and again, it's going to be another useful tool to put in our tool bag.
Thank you, Dr. Eller, for that presentation. We have a lot of interest on the topic. We've got a lot of questions. We'll do our best to answer as many of them as possible in the next 22 minutes that we have left. If you've got questions that you've been holding on to, send them through. We'll be working through those, and we've got Dr. Eller with us as well, to be able to help us answer those. So we'll jump straight in. We had a question from Nerida who said that, do I need a neurologist to access these medications? I think particularly she's referring to CGRPs, antibodies. She lives in a rural area, so it makes it a little bit difficult. How would you respond to that?
Yeah, listen, unfortunately, this is the barrier to access to these medications. You do need a neurologist involved in your care, so they need to go through the diagnostic criteria, confirm that you basically qualify under the pharmaceutical benefit scheme, or if you just have episodic migraine, or you've got chronic migraine but you haven't gone through the trial of 3 different migraine preventives, or have relevant contraindications, getting it on a private script through a program like I talked about. Neurologist needs to be involved, certainly in the first initial part of the prescription. Once you've been prescribed the medication, it is possible for general practitioners to provide ongoing scripts, but the neurologist needs to have an ongoing involvement in your care. So, there are barriers around access. Many parts of Australia don't have neurologists, and telehealth is a second best sometimes, though can be useful in headache neurology. So, yeah, not easy, unfortunately, but that's where things are at.
Kim asked if you do telehealth consults yourself.
I do, but typically as a second review. So I typically try and see patients face to face the first time, almost always, and subsequently, reviews via telehealth are reasonable for all sorts of reasons. In the height of the pandemic, we were seeing new patients, relatively commonly in a hospital and private context, as via telehealth, but that's changed a little bit. So you'll find that different practitioners will have different preferences and different practices. By rights you can, and to be fair, it's a bit different to movement disorders or some other branches of neurology. Often you can get away with telehealth for a first appointment.
So we've got a bunch of questions to work through, so I'll try and move through these as quickly as possible. But there's
Sure
quite
thing.
a few that actually refer to other types of headache. They're not the vanilla migraine type. So one example of that is Ben, who said who wanted to know whether the CGRPs work for cluster headache as well as migraine.
Okay, I mean, that's an excellent question. Many people will be aware that a lot of the primary headache conditions, they do have a lot of overlapping both phenomenology, like the different elements like light sensitivity and response to treatment as well, like verapamil, which can be used in migraine and cluster. So it won't surprise you to know that when medicines like Galcanezumab became available for trial in humans, they were used on people with cluster headache. So there are trials around that drug, for example, for episodic cluster headache and chronic cluster. The episodic cluster headache trial was positive, though relatively weakly so, and it led to its being licensed as a drug for use in episodic cluster headache in the USA, but not in Europe because of the data. And but listen, there are individuals who do respond to that drug. If you happen to have comorbid migraine, so if you're an individual with both migraine and cluster headache, it's possible that a neurologist in Australia would be able to prescribe the medication under, within the spirit of the TGA listing, but you wouldn't be able to get it under the PBS unless you happen to have chronic migraine, you failed 3 medicines, and you happen to have cluster headache sometimes as well, which does happen, but that's relatively rare. The doses of Galcanezumab that were approved in the States was 300 milligrams, and we use 120 milligrams here in Australia monthly.
So Madison had also asked about that as well. So hopefully that clears things up for Ben and Madison. Natasha asked about abdominal migraine for using CGRPs for that.
Yeah, I guess the first that tends to be in a pediatric context or childhood context. I have seen it in adults and certainly people with chronic migraine or episodic migraine, where more typical symptoms of head discomfort and light sensitivity. Some individuals within that context have a lot of abdominal symptoms. I'm not aware of any of the monoclonal antibodies being tried in a pure population of abdominal migraine. And I think it'd be quite a hard study to do because, often, particularly in the pediatric context, it's a diagnosis of exclusion. You're ruling out a whole bunch of other things as a cause of intermittent, abdominal pain. So it's an interesting question. It may well have some benefit, but no data that I'm aware of. And I think it'd be a devilishly hard study to do. And there's a collective wariness about trialing these medications in the pediatric population.
Gail was asking about TMJ and whether these treatments might help with that, for example.
Okay, so for people with chronic migraine in particular, it's very common to have some degree of temporomandibular joint dysfunction. So TMJ is the trigeminal mandibular joint. So it's literally a joint, just like a knee is a joint. But you can develop dysfunction around it. It's not, and that can reflect a number of different elements. So it might be the jaw is clicky, or it can get stuck open or closed, or you can't open your mouth properly, or perhaps more commonly in people comorbidly with migraine, as in this at the same time they have migraine, they can clench and grind, and there's a general feeling of tightness around there. So for most or many people with a lot of migraine, they go on a journey which involves, a diagnostic journey, which involves seeing a dentist along the way, or a number of dentists, often diagnosed with TMJ, trialed on mouth guards or splints at night to see if that helps. I'm giving you the long answer, the long way around. So that's the context of that condition. So for people with migraine who happen to grind or clench, if they respond to these monoclonal antibodies, for example, that turns the dial down, shall we say, and any input from being uncomfortable from clenching, or because the joint is eroded and worn, that'll be dialed down. So in short, if it works for your migraine, it'll probably turn the dial down on your temporomandibular symptoms too.
Okay, great. So we might try a couple of rapid fire questions. So if you can maybe answer in sort of a sentence or two and try to limit it to that. And that way we'll jump through as many other questions because we're not keeping up. We've got a lot of questions.
Okay, I'll try harder. Yeah.
So Catherine asked, can you answer the question about long-term cardiovascular safety of CGRPs, for example, stroke risk?
I'm not aware of any data regarding increased stroke risk. That's the short answer.
Great. We'll take that one. Sarah asked about whether the CGRPs are safe for breastfeeding, for women who are breastfeeding.
That's a short one too. The answer is no. So monoclonal antibodies, just like if you're a mother breastfeeding a child, you hope that some of the immune cells, some of the antibodies will cross into your child and give that child some degree of protection against viruses and other problems. Similarly, monoclonal antibodies like Eptinezumab, for example, you'd expect that it would cross into breast milk to a proportion and have an unknown effect on the developing young baby. So I'm not aware of any data on it, but it's not something that would be considered done.
Okay. Some of the things that come up, a few people have mentioned some unlisted side effects. You mentioned in your presentation that overall the efficacy and side effect profile for these treatments are excellent. Julie was wondering about hair loss, which isn't listed as a side effect. Why might that be?
That's listen, there are a number of relatively less common side effects. Hair loss, absolutely. So there are I've got maybe 5 patients who've suffered some degree of hair loss in relation to monoclonal antibodies. Most of them not particularly profound, and all of them reversible if they happen to stop it. But no, that is something that's been published on, certainly case studies. My take is it's probably 1 in 200 or 300 people. That's a rough guess. Will have a degree of hair loss. But that's a real thing, and it's plausible from a scientific basis because CGRP can affect the hair follicle, or is involved in the hair follicle health.
Sally mentioned one of the CGRPs like exacerbating her inflammatory arthritis. Is that also possible?
Also possible. So we've recently published a series of autoimmune conditions and how some of them can be flared by the CGRP monoclonal antibodies. Arthralgias, which is just discomfort around joints rather than inflammation, can also occur as a side effect from these antibodies. So it's an emerging space. CGRP pathway can affect the immune system. And there are case reports of people who do have a flare of an autoimmune condition while they're on the medications. Having said that, many people with autoimmune conditions like rheumatoid arthritis or inflammatory bowel disease don't have any problems. It's certainly part of a discussion, and that's what I was alluding to earlier. If you do have a comorbid medical problem, you need to tell your neurologist all of the different elements about, have that discussion about risk versus benefit.
Yeah, and I would imagine also telling them if you are getting treated by, for example, a pain specialist, what treatments you're getting from them too.
Absolutely, yeah. I mean, every doctor always wants to know about what the full list of medications are. I mean, we don't want to be at cross purposes, and we want to work together.
So Nora has said that she's been on a CGRP for 6 months, had a 50% reduction in migraine attacks, which is fantastic, but she has nausea at nighttime. Do the other CGRPs have, like, if she has that with one CGRP, is she likely to have that with others? Is it worth trying another one?
Yeah, I think it is. There's a significant benefit, and that's an unusual potential side effect. Maybe it is related to that particular medicine. So, for example, if it happened to be Ajovy, it'd be absolutely worthwhile seeing how she goes on Emgality, which is also on the PBS, just for example. And maybe that nausea would settle down.
Going back to other disorders with migraine, Kylie asked about idiopathic intracranial hypertension. Are the CGRPs likely to be helpful for that? Has that ever been studied?
Can. So, for people with IAH who have who fulfill criteria for migraine, and it's a very common overlap population, you need to go after both sides of things, and for many people just getting the pressure down is enough to decrease a lot of the migraine symptoms. But for other people, even if the pressure's way down, eye symptoms are improving, and that's the IAH side of things is all on the right pathway. Whatever the intervention was, if there's still ongoing very significant migraine symptoms, then absolutely calcitonin gene-related peptide medicines can help with that, as can any migraine preventive. Sometimes we use topiramate, for example, in that context, or even Dimox, which is used for IAH. Both of them can actually help with migraine symptoms, irrespective of their effect on intracranial pressure.
We've had a lot of people asking about hormonal migraine in general, and Rihanna specifically asked about the CGRP's effectiveness for hormonal migraine.
Yeah. For migraines that are particularly influenced by hormonal flux, just like migraines that are not, they can respond very well to the monoclonal antibodies. So certainly many of my patients who have worsenings a few days before their periods, for example, that can melt away, just like the migraines outside of that context can also melt away. There probably are some studies out there. I'm not aware of specific ones, but absolutely it's worth trying if some of the other measures haven't been effective, for sure.
Ali asked, how long do the CGRPs generally take to work?
It's a bit of a piece of string question. If you're talking about Vyepti, it can be within hours. Pretty remarkable. That's the infusion. For some of the subcutaneous injections, it can be hours to days even. But typically, for many people, it's the first month. But there are also people who only start responding in the second, third, or even the fourth or fifth month. So we look for that 50% improvement in migraine days by the end of the third month. And under the PBS, if you do fulfill that criteria, then you can go on and keep getting it. And often, at 6 months or 1 year, you might be someone that has a lot less migraine burden than you did at that 3-month point. So, people can either plateau once they get a benefit, or they can get better and better. It's really variable.
Eric asked about, he said that his CGRP has been taking it over the last 18 months. It hasn't reduced the frequency, but it seems like it's reduced the severity to some extent. Is that supported by findings in the research for some people?
Oh, absolutely. So, I think I talked about that in the talk. You might be someone that has exactly the same number of migraine days, but your intensity has gone from 8 to 2, or it's gone from 8 to 5 out of 10, but you've become very responsive to a triptan like Maxalt, for example. So it just becomes a really manageable problem as opposed to before. So no, the intensity is huge. That's why quality of life metrics are often more important than headache days or migraine days, which neurologists get hung up on.
And we'll take one more question from Sharon, who also had someone else ask a similar question, which was, does the migraine trigger affect what type of medication is prescribed?
Usually not, is the short answer. So, or whether it's occasionally you'll think about it. So, if you've had a bad sleep and you're trying to find which oral migraine preventive to try, you might go after something like tricyclic antidepressant like nortriptyline, rather than trying a beta blocker like propranolol, just for example. But in terms of does a particular trigger like light or stress or letdown from stress mean that you're more or less likely to respond to a monoclonal antibody against CGRP or Topamax, for example? No, it doesn't. It doesn't help us, unfortunately. In the future, we hope we'll have more personalized medicine and more data. Maybe we'll work out some of those associations.
Yeah. The only other example besides sleep that I can think of is maybe hormonal factors and specific treatments that sometimes are used over the the menses time of the month.
Absolutely, that's true. That's a special case.
Yeah. Excellent. Well, thank you so much, everyone, for joining us today. It's only the first talk of 6 that we have over the week. And we're going to be covering a number of different topics. I want to thank Dr. Michael Eller for generously donating his time and expertise to join us tonight. And also to let you know that coming up tomorrow, we've got Aging with Migraine with Dr. Catherine Spira. And I also saw that there are a number of questions regarding new daily persistent headache from Kim, Karen, Fiona, and others. We're going to be covering that topic with Dr. Jason Ray on Wednesday at 11 a.m. in the morning. So definitely tune into that. Make sure you send in your questions and we'll do our best to get all of those answered. But I want to thank absolutely everyone in the audience. Thank you for all the questions. This was clearly a very interesting topic that a lot of people got some value from. So thank you, Dr. Eller, and thank you everyone else.
Thanks, Carl. Thanks, everyone. Thanks for the opportunity. See you later.
Have a great night.